Okay, guys, I'm going to try to get through the conclusion a little bit of chapters 5 and 6 for you, just with some explanations, something I didn't get to in the other mini lecture. So this is sort of a supplementation for both chapters 5 and 6. That's the integumentary system and bone/skeletal system. So I'll start with how chapter 5 wraps up. Let me share a screen, get on the whiteboard. And I did want to say a few things about, I don't have time to go into alopecia and male pattern baldness, so please read those on your own. I will ask you one or two questions on the next quiz, but I would like to talk about burns, skin burns, or burns of the skin. What happens when skin tissue, when integumentary tissue is burned, epithelial tissue and dermal tissue as well, is it denatures proteins, and that is something that happens to proteins when significant heat is applied to them in general. You can take a protein in the lab, heat it up, and it denatures it. What that does is it breaks peptide bonds. It breaks bonds in the protein, and the protein starts to unravel and become dysfunctional. So it denatures proteins, burning skin, as well as it kills cells. The absolute first main concern in any sort of significant burn is loss of body fluids. That's the acute concern, meaning the first immediate concern. Now, as most of us know, burns are categorized based on first degree, second degree, and third degree burns. And so I'm just going to quickly go through that. First degree burns affect mostly just the epidermis. So those 5 layers of the epidermis, typically first degree burns don't affect the dermis, but mostly doesn't mean always. So sometimes a first degree burn does go down into the very upper layers of dermal tissue, that papillary dermis. Example of a first degree burn, classic example, is sunburn. Severe sunburns can go down into that papillary dermis. Typically, though, it just affects the epidermal layers. A second degree burn goes deeper in the dermis. And you know that dermis is where the vascularization is, the blood vessels and the nerve endings. In a second degree burn, blistering occurs because it is deeper in the damage is deeper in the dermis. And third degree, and by the way, these are considered, first and second degree are considered what we call partial thickness burns. Third degree burns, of course, are the most severe. This is what we call a full thickness burn. The entire skin layers. So we've got all 5 layers of the epidermis being affected, being burned, as well as papillary and reticular dermis. This severe type of burn destroys nerve endings. So oftentimes during a third degree burn, some of the pain is not exhibited as it is in these two because nerve endings are destroyed. And so sensory nerves that detect pain are destroyed in the process. So I'm just going to write Oftentimes during a third-degree burn, there's actually little pain. Once again, loss of body fluids is the main acute concern. Oftentimes, the only remedy or treatment, real treatment for a third-degree burn is a skin graft. Now, there is other long-term concern like infection. So invasion of infection is a very real concern, but it's typically after the acute phase of loss of fluids. Usually people who die from severe third-degree burns die from loss of body fluids. But I'm going to write invasive infection is a secondary / long-term concern. I'm going to try to save white space here. So I'm going to cram a few more things in because I'm almost off of skin burns. A critical burn, we determined that a burn is classified as critical if over 25% of the body has a second-degree burn. So critical will be classified if greater than 25% of the body has second-degree burns, or if over 10% of the body has third-degree burns. Actually, degree is just, I'll be consistent here. Degree is just literally a degree mark, so let's be consistent. Third-degree burns. There we go. All right, I'm going to now briefly just identify the three major types of skin cancer. The major #1 risk factor for skin cancer is overexposure to UV light. And there's three main types of skin cancer. I'll just number them 1, 2, 3. First one is basal cell carcinoma. I'm sure you've heard these names before. Obviously, this affects the basal cells in that epidermal layer. So basal cell carcinoma is by far the most common type of skin cancer. So let's establish that. It is also, thank goodness, the least malignant of the three. Malignancy means life-threatening. It's also very slow growing. Malignancy means life-threatening. Metastasis or metastasis means the cancer spreads to other places in the body. Here's what happens during that basal cell carcinoma. The basal cells, they multiply and start to go deeper in the layers of the skin. That's all cancer is really an uncontrolled replication of cells, an uncontrolled multiplication of cells. So basal cells multiply and then invade the dermal layers. Even down into the hypodermis, which is below the skin. It's mostly adipose tissue. Also, an ulcer shows at some points an ulceration on the surface. So during this multiplication of cells, here's our surface of the skin, here's that stratum basal layer of the epidermis. This is dermis, both papillary and reticular. So these basal cells in the epidermis uncontrollably multiply, and those new cells move this way down into the dermis and this way toward the surface, where we get the ulceration. The treatment of choice to get rid of this type of cancer is excision. So not something like chemotherapy or anything like that. Excision of cancerous cells is the preferred treatment. Right, number two, second major type of skin cancer is squamous cell carcinoma. So remember the squamous means flat. We learned that a couple units ago. So what's happening is the flatter cells higher up in the epidermis up here are the cells that are cancerous. It's the second most common type of skin cancer. Keratinocytes are affected the most. I'm just going to write keratinocytes of the stratum spinosum is where it originates. Remember, that's just above the stratum basal, but it's also much thicker than the stratum basal. The parts of the body that are most commonly affected by squamous cell carcinoma are the scalp, the head, and the hands, typically the tops of the hands, not the palm. And these are the most commonly exposed parts of the body to sunlight. This cancer, unlike basal cell carcinoma, grows very rapidly. It is not slow growing. It also has a tendency to metastasize. Metastasizes. That just means spreads to other parts of the body. This type of therapy or treatment is excision. Excision, to excise something, means to remove it from the body. So physical removal is the preferred choice in all cancers, by the way, but you typically don't use chemotherapy in this type of cancer up here or immunotherapy, but excision and or chemotherapy is recommended in squamous cell carcinoma. And third, last but not least, is malignant melanoma. So number 3. Melanoma, just like the name suggests, affects the melanocytes. So it's cancer. Remember, melanocytes are also found in the stratum basal. They're just not the stem cells, they're the pigment-producing cells. This is by far, it's not common, it's the least common of the 3, but it's by far the most dangerous. It is highly, highly metastatic. That means if left unchecked, it is somewhat slow growing, so I'll put that. It is relatively slow growing, which is good news for us humans. Highly metastatic means it almost always, if left unchecked, spreads to other parts of the body. So oftentimes cancers, where they originate, are not malignant, they're not life-threatening at that original site. For example, breast cancer, cancer cells in the breast are not life-threatening, just like cancer cells in the melanocytes of the skin themselves are not life-threatening. It's when they spread to other parts of the body, which is what metastasis means. And when they spread to other parts of the body, this particular cancer, melanoma, likes to take up residence in the brain. So oftentimes the secondary site is brain cancer for people afflicted with malignant melanoma, if it's left unchecked. So we know that it affects the melanocytes, and an appearance of this cancer does appear on the surface of the skin, which is a good check for us. So I'm just going to write appearance on skin. Similar to basal cell carcinoma, here's the surface of the skin. Here's our lowest layer of the epidermis. The melanocytes now are located at this basal stratum basal layer. When they become cancerous, they start uncontrollably dividing this way, deeper tissue, and up to the surface of the skin. If caught in time, when they appear on the surface of the skin, recovery from this is the percentage is very high. But if left unchecked too long, what happens is the cancer cells that move this way go into deeper tissue, and unfortunately they end up in the fluids of our body, like in the blood. I should have made that black. Like in the blood or in our lymph tissue. When that happens is when they spread to other vital organs, which is of course not good. A 4 millimeter thick or more depth here of tissue, of invasion of cancerous cells, is sort of the tipping point of poor survival. So 4 millimeters or greater typically indicates a poor chance of survival. That's what oncologists typically go by. Treatment of this, of course, is excision, especially at early stages. We just want to cut it out. So excision is always the preferred and best treatment, but also in this case, immunotherapy has turned out to be a great therapy for this type of cancer. All right, now we're off of the integument. I'm going to try to finish up some topics in chapter 6, which is bones and skeletal system. So we're totally switching gears here. I'm going to start off with, I'll just remind you, this is chapter 6 now. Let's define some terms. First one is osteopenia. This condition, osteopenia, refers to what it translates to is lack of proper ossification. That's what it literally means, but in layman's terms, it is just the thinning of our bones that normally occurs or typically occurs with age. So this is thinning of bones. And I'm going to write the word typical because it is fairly normal. All of us, our bones start to thin if in mid to late life. I'm going to write with age. So just remember that osteopenia is a normal condition that occurs, that comes with age. And what happens as we age is that osteoblast activity, this is normal, decreases, goes down. And osteoclast activity stays at the same rate. And if you think about that, these cells create new bone. These cells dissolve, break down bone tissue. If the creating new bone tissue slows down, but the dissolving bone tissue keeps chugging right along at the same rate, our bones obviously will get thinner as we age. Typically, females, I'm just writing women, typically women lose up to 8% of bone mass per decade after age 40. That's a high end. So I'm going to say up to 8% of their bone mass per decade after age 40. That's a lot. And it usually is coincided with menopause. So after a female stops ovulating, which is really a result of the change in hormone profile. But during that time, a negative deleterious result of that is that bone thickness starts wearing away, starts thinning. Men are not quite as afflicted with this, but they still lose up to about 3%. So men lose up to about 3% of bone mass. That's per decade after age 40. So it becomes quite significant. The most affected areas of the body, not the only ones, but the most affected, most commonly affected area are epiphyses. You know what that word means now? It means the ends of long bones, the vertebrae, and the mandible, which is the lower jaw. All right, this term, osteoporosis, is the one we all hear about. Osteoporosis is really just a more severe condition of osteopenia, a more severe form, I should say. And what happens is in people who are classified with osteoporosis, their bones thin to the degree where there's compromise in structure and function. So basically, people with osteoporosis have so much bone thinning, so much osteopenia going on to a severe enough degree that the structural integrity of those bones is compromised. So we know that fragile bones, if they get thin enough, easily break. And when an individual is at chance of fracture, we say they have osteoporosis. The main cause of all of this stuff is decreasing levels of estrogens and testosterone. Those are called steroid sex hormones. The sex word is used just because they're classified as male and female hormones. Both males and females have these hormones, just in different quantities. So I'm just going to write steroid refers to their biochemical design or makeup. They're steroid sex hormones. And as we age, they decrease. In men, the decrease of testosterone production occurs really after about age 30, but it's a slow, in most men, it's a very slow, steady decrease. Women, postmenopausal women, the drop off of their estrogens is a lot more acute, much more severe. All right, that leads us into bone fracture and repair. Bone fracture and repair probably might even come before osteoporosis in your chapter. It doesn't matter what order we do this. there's different types of common bone fractures. So I'm just going to list the names. I would like you to look at, I think it's table 6.2 in your book. I'll write that here. Table 6.2. Table 6.2 lists, classifies, and gives X-ray pictures of the 6 major categories of fracture types. And those are just comminuted, C-O-M-M, comminuted, spiral, depressed. The names pretty much clue you into what type of fracture it is. Compression, which is similar to depressed, not quite the same. Epiphyseal, you can guess what that's going to do. This one's actually a dislocation almost. They consider it a fracture, but it's almost a dislocation. It's at that growth plate area in long bones. And finally, green stick, which is most common in young people, very young, adolescents, children. I would like you to familiarize yourself with these names, what they mean, what type of fracture they mean. Really quickly, comminuted means a fracture in which there's 3 or more pieces, separate pieces in that type of fracture. Spiral literally means typically on a long bone, oftentimes in the tibia, where the fracture looks like a candy cane. It's a spiral shaped fracture. That's very common in athletes. Depressed is next. Typically, depressed means sort of crushing the skull. The skull is a cavity, a big cavity that contains soft tissue in it, obviously central nervous system tissue. Compression refers to the sort of what you and I would call indentation fracture on the skull. Compression, that just means fracture due to forces of downward force against gravity. Typical compression fractures are vertebrae. So here's a vertebrae from a lateral view from the side. Compression fracture would be breaking this vertebral body. Epiphyseal, that's almost like think of it as almost like a dislocation. It's a breaking away at that epiphyseal plate, usually in the area of that hypertrophic zone and calcification zone, right where calcium's being deposited into that weak cartilage area is where we find those epiphyseal breaks. And finally, green stick. In young people, because their bones are growing so fast and there's so much organic matrix in those young people's bones, they tend to be softer. I'm putting that in air quotes, softer bones, and they're more flexible. So the reason it's called green stick is if you were to take a branch from a tree that's completely green, meaning the tree is still living, and try to break it, it's difficult. First of all, the branch will bend to a large degree before it breaks, and then once it breaks, that break almost never goes all the way through the branch. Same with a green stick break in a young child. Finally, I want to talk about a few bone diseases. Oh, let's do repair. That was bone fracture types. Now I'm going to talk about repair. I'll do that next. So repair is oftentimes dictated by the fracture classification. Those 6 categories that I just wrote on the previous page, these are fracture types, okay? Specific fracture types. There's also fracture classification, which is just 3 categories. I'll write them out really quickly. And the common fracture classifications, we classify fractures based on position. What that means is where the bone ends of the fracture are positioned relative to each other. So if they're still in alignment with each other, or if they're completely misaligned, that's what position means. The second category that we classify fractures is complete or incomplete. And that just, does the fracture go all the way through the bone or just partially? through the entire bone. And finally, closed or open. That means, are the bone ends, have they broken the surface of the integument of the skin? Open is also known as by the word compound. So an opened or compound fracture, this is the surface of the skin. We break a bone underneath. The bone actually protrudes through and breaks the skin surface. That would be open or compound. Closed would be if the broken ends do not penetrate the surface. Okay. Now I'm going to list the stages of typical bone repair. So what happens to the bone tissue after it breaks is what this is about. And there's stages in chronological order. The first thing that happens is after a bone break or fracture is a hematoma forms. I don't have time to list out every little detail to this, but basically what a hematoma, you and I know as a bruise, it means ruptured blood vessels and therefore blood cells accumulating underneath the skin. So a hematoma forms, which is just a mass of clotted blood that accumulates at that fracture site. Cells die, living cells start to die, and the tissue swells. So we get, I'm just going to write blood clot and inflammation. We also get, obviously living cells start to die as well. Second stage of repair is a fibrocartilage callus forms. I'll try to draw a picture after I list these stages. Fibrocartilage callus forms. This is better shown in pictorial form. So blood vessels or capillaries start to grow into the injured area. They invade the area. During this stage, immune cells, phagocytic cells, macrophages, they clean up debris. They break down old dead cells and they keep infection away as well. Then fibroblasts and chondroblasts, osteogenic cells, all of these producing types of cells invade the area and start laying down new bone. But the first thing that happens, what a fibrocartilage callus means, let's just do a break here of a bone. We'll say it's still aligned. First, a hematoma forms, a blood clot forms. I'm not going to draw that. Inflammation occurs in tissue. Chemicals are released. What a bony callus, fibrocartilage callus forms, is it almost, we get fibrocartilage forming to bridge this break, like this. The blue is the fibrocartilage. So cartilage, actually, it looks like a little cast. A cartilage cast forms in that break area. And I exaggerated the distance of the two bones after they were broken. Typically, that's all. It's ridiculous. It's not that far apart. So a fibrocartilage callus forms after all of the first things that I mentioned, and it splints those broken ends together. Third step, and is a bony callus forms. That's a C-A-L-L-U-S. All that means really at the end of this stage of repair is that bone tissue will replace that cartilage tissue. So fibrocartilage first becomes bony trabeculi. So we get spongy bone always forming first. Remember we said that when we talked about ossification. So spongy bone, I'll write trabeculi, replaces fibrocartilage. You need to go over these stages in your book. Just read through them, but I'm giving you the gist of it. And then a bony callus forms in that site. So I'll use black. We get spongy bone replacing fibrocartilage, and it amasses in this area to help splint that tissue even further. Bone tissue is harder, more dense than cartilage tissue. The endochondral ossification process sort of still proceeds for about 2 months. So this replacement of cartilage with spongy bone lasts roughly about 2 months. That, of course, differs depending on the severity of the fracture. Then the bony callus is remodeled. So I'm just going to write number 4 over here to save space. So last but not least, this is the last stage. The spongy bone that I've drawn gets remodeled into compact bone. That's a long process. It may take up to a year to occur. Now, typically, I'm going to say this for those of you who are tuning in and watching this, rarely does a bone ever break in the same place twice. The reason is because that new repaired area is actually stronger. A, because it's new bone tissue, and B, because it usually is thicker than the bone tissue around it. So I'm just going to fill in this new bone, this new compact bone. I've exaggerated things just so you can see the point. Rarely does a bone ever break in the same place twice, because if this bone, this repaired bone now, is subjected to trauma in the future, this is weaker here and here than it is here. So a bone almost never breaks in the same place twice. Never is a strong word, so I'm just going to say almost never breaks again at the same spot. And now you know why, because that new tissue is actually stronger than the surrounding bone. Okay, those are the stages of bone repair. All we have to do is quickly cover a few more bone diseases, and we'll be finished. So we've already gone over osteoporosis. So I'm going to not really spend much time on that. I will talk about these terms. Osteomalacia. This literally means soft bones. So our bones get softer. And it's because they're poorly mineralized. So for whatever reason, we're not getting enough mineralization in our diets, and therefore there's not enough minerals in our blood for proper calcification during the process of ossification. A disease that results from poorly mineralized bones is called rickets. That's supposed to look R-I-C-K-E-T-S. This is a lack of mineralization, usually affecting young people. And because the bones are poorly mineralized, it's the minerals that give the hardness to our bones. Their bones are softer, easily break, and they also get malformed, mal-shaped. So I'm going to put risk. Sorry, I'm trying to write on a very vertical glass board with a plastic pen. The risk factors that present osteomalacia or rickets is insufficient calcium in the diet or lack of vitamin C. So too little calcium that we get from our diet, and also decreased vitamin D3. So if a person doesn't get any sunlight at all on their skin and their body therefore doesn't produce vitamin D. We've been through that. That's why we fortify things that we ingest with vitamin D, like dairy products, for example. So when we drink milk, we're not only getting the calcium in the milk, we're also getting fortified vitamin D to make up for any loss of vitamin D. Paget's disease. Whenever I hear the term Paget's disease, it's almost the opposite situation of osteopenia and osteoporosis. It's the abnormal production of bone tissue. So it's abnormal ossification in the sense that these bone layers get laid down on bone abnormally at an abnormally high rate in very strange but specific areas of the body. It usually affects places on the body like the vertebrae. So I'm just going to write spine. It's a very typical area. The pelvis, the femur. Femur is the upper leg bone. The skull. And the bone that gets laid down in these places is abnormal in constituency as well. It's typically kind of weak, spongy bone, not really strong, hard, compact bone. Paget's disease presents itself as very painful. Therapies for this include drugs, usually calcitonin and biphosphonates. Bisphosphonates, some people say. Bisphosphonates. And what they do is they help with bone breakdown. So this bone, because it's so quickly made and abnormally made, it's also this very weak, strange looking bone. It's not solid. And calcitonin and these drugs help properly mineralize that bone as well. It helps prevent bone breakdown. All right, guys, I'm going to cut it there. If you have any questions, just let me cut off my recording here or off.